Thank you, and I want to thank all the panelists. We're going to have questions now. Each member gets 5 minutes, as you probably know, and I'll start out with myself. And I wanted to ask Mr. Kingsdale, you have achieved remarkable results in Massachusetts with your two connectors. Our national rate of uninsurance is 17%. In Massachusetts, just 2.6% are uninsured. But to achieve this result, you have in place a requirement that all residents must have health insurance coverage that meets minimum standards for adequacy. And I just want to ask a few questions about this individual mandate and how you ensure that the coverage people are required to buy is affordable. First, what type of coverage does, I have 4 questions, so I'm going to try to go quickly here. What type of coverage does Massachusetts require its residents to have, and how is that individual mandate enforced? Of course, I heard about this during the presidential campaign, but I want your opinion.
Sure. Thanks for the question. So we have, if you require insurance or anything, you have to set a minimum standard. Obviously, $1 of coverage per year does not constitute real insurance. And that's been one of the 2 thorniest problems which the legislature in its wisdom asked the board of the connector to resolve rather than to do in legislation. And we have used a couple of principles to develop what I would call minimum creditable coverage. One is that, like any insurance, it ought to protect people from catastrophic costs. So there are some maximum cost sharing elements to it. And the second is that because this is health care, which does differ in some important respects from other kinds of insurance, we actually require coverage up front of preventive care before a deductible, and coverage with or without a deductible of a broad array of services such as you would expect from coverage in your own health plan.
And how about the enforcement of the individual mandate?
So the enforcement is through the tax code. The enforcement has been on the principle that it's good to have insurance and we want to help you get there, not gotcha. So the actual requirement went into effect July 1 of 2007. As long as you had insurance by December 31st of 2007, you did not pay a penalty, and if you did not have it, the penalty was pretty modest, $219. That penalty goes up and becomes month by month as we move into 2008 and 2009. We have exceptions for religious beliefs, a much bigger exception for affordability. Of course, we have significant subsidies to low-income people who are not eligible for employer-sponsored insurance to help them afford it. And then we have a robust and generous appeals process for individual cases. So we look over backwards to try to get you there rather than penalize you for it.
Let me see if I can get to these other 3 questions. How did the state decide what combination of premiums, deductibles, coinsurance, other out-of-pocket payments were affordable for individual and families?
That's the other very tricky question. Again, the legislature asked the connector board to do that. And we kind of did a bookends approach. So at the bottom of the income scale, 0 is affordable, and we defined that as 150% of federal poverty level. That's a fairly arbitrary decision, but a gut check. And at median income, and ours is a wealthy state, so that's about 550% of federal poverty, we said you have to have insurance. There is no exception for affordability. And in between, we basically do a scaled progressive schedule, but the principle underlying that is that by the time you get to 200 to 300% of federal poverty, so that would be an individual making $21,000 to $32,000 a year, where 80% of our citizens who are get their insurance through employer-sponsored insurance pay something like about $100 on average per individual per month toward that. We thought that was a reasonable affordability basis. It had political equity, it would reduce or avoid crowd out, and it seemed sort of gut check fair.
Now what about, have any studies been done to determine if rates of medical debt or bankruptcy have declined since Massachusetts achieved this near universal coverage?
It's a great question. I actually have asked several times to have such a study done. It's on somebody's project list, and I keep looking for outside research to do it. I'm hopeful that the answer would be medical bankruptcies would go way down. You compare 08 to 06, but we have not done the study.
Well, let me just ask Ms. Politz this issue again with the individual bankruptcy or debt. There was a study published by the Center for Studying Health Systems Change that showed that 75% of those with medical debt in 2007 were actually insured. they had health care coverage, but they still had debt. Can you explain that? I mean, this whole issue of people who actually have coverage going bankrupt or going seriously into debt.
It can be a number of different factors. It could be that their policy doesn't cover all of the services that they need. It may not have a prescription drug benefit. For example, if you have HIV and you don't have a prescription drug benefit or MS or something that has a very expensive pharmaceutical need, then you could run up very high medical bills because those services aren't covered by your insurance. There may be caps on what's covered. You see policies that only pay so many mental health visits a year, and then, a kid gets an eating disorder, or a policy that, caps total benefits at $10,000 a year, and then you have a heart attack that costs $100,000. So that can happen. Typically, the literature on medical bankruptcy suggests, though, that it's not six-figure medical debt that is sinking families. On average, it's less than $12,000 or $15,000 in medical debt that'll run a family over the limit and lead them to declare bankruptcy. And so we need to also look at cost sharing, and cost sharing that we might think of even as modest. One study that I cited in my testimony looked at medical copays in the range of $6 to $25 and what those meant for people with chronic conditions, asthma, diabetes, and so forth. If you're needing to, take medication several times a day, every day for your entire life, and you're always refilling these prescriptions, those little copays add up and become thousands of dollars. And if you add on to that deductibles, copays for other medical care that you need, it really adds up remarkably quickly.
Okay, thank you. Mr. Deal.
Thank you. I want to get my transparency question out of the way real quickly. I think most of you were in the audience and heard my description of the proposed legislation. And I just go down the list. Do you generally believe that pricing transparency is something that we need to enhance in our system, regardless of what that system may ultimately turn out to be? Ms. Kaufman, start with you and we'll go down.
Thank you. I think it's critical when you have a private market to have transparency, to provide consumers with useful information they can understand and use in making decisions. Right now, if you were shopping around, you couldn't get your policy ahead of time, the full contract. You can get a benefits description, which may or may not be accurate. So transparency, in my view, includes everything from how your contract, how your insurance will work when you need it, to choosing your provider, and to making more informed choices from start to finish. Right now, that just does not exist in the private market.
Dr. Kingsdale.
I would strongly endorse the idea of making prices and benefits and everything else transparent. In fact, in our programs, that's exactly what we do. I've been in the insurance business for over 25 years before becoming a bureaucrat, and I'm pretty realistic about how much is achievable. Price is absolutely another information requisite to a functioning market, but so is competition. In Ms. Kaufman's state and in most towns in my state, you don't have but one hospital, period. So you can know all you want about their prices. You really don't have a choice, and so it doesn't do you much good. Right. So I'm realistic about what you can do with it.
But even in those situations where there's one hospital, who you are and who's paying the bill will determine what the price from that one hospital is, because you've got negotiated prices by government agencies, you've got negotiated prices by private insurers, and generally the ones that wind up in the bankruptcy court are the ones who don't have anything, and they generally charge the highest price of all. Ms. Politz?
I agree it's very important, and I commend you for your legislation, and I would just agree also that looking at all of the dimensions where transparency is necessary is important to do, and I hope that'll be part of this effort as well.
Thank you. Dr. Beck?
Agreed. Transparency is a prerequisite for a well-functioning market, and the prices that we could publish now would be very useful, and even more useful would be building together bundles of prices that would really let people choose how much does it cost to have this condition taken care of by this group, not line by line that's harder for them to aggregate, but you have to start with what's available.
Right. Mr. Amsler?
Yes, Congressman, as I mentioned in my remarks, I do agree with you on that. I would simply, as I mentioned in my remarks, encourage everyone to recognize that this is one very important piece of the puzzle, but it's not the only thing. To follow up on what Mr. Kingsdale was saying, the first question is, what does it cost? The next question is, what am I getting for my money? And that's where you start comparing the data on quality and outcome. So you always have to ask that first question before the second question gets asked. That's true. There are ways where you can do that not only in insurance but also in the provider side, which is really important. And I would also encourage folks to think not about the consumer versus the provider interaction, but creating a common data set that all the insurers can use to act as the agents, as the experts on behalf of the consumers in these decisions. And so a number of states are looking to do that. And I think the regrettable thing about it, if Massachusetts' mistake in the beginning was not to have a risk adjuster, their mistake in implementation was that the governor and this administration recently cut back the Cost and Quality Commission that was designed to do that in the legislation.
Could I follow up with in less than 3/4 of a minute? Would you contrast the Utah situation with the Massachusetts? What improvements did you think they made that were important? What other changes, if any, would you suggest a state look at?
Well, I think the most striking thing about this, and you all as members of Congress will probably think of the very different politics of those states, but I would encourage you to realize that the most striking thing to me about this is when you rank the 50 states by the per capita cost of health care, Massachusetts is the single most expensive and Utah is the absolute cheapest. So those are vastly different in their health care systems. That said, Massachusetts had a large amount of money that it was giving to hospitals, public dollars, to pay for the uninsured, which is now being converted into buying those people insurance. Utah's on the other end. They have almost no public money going to insurers. So what they are doing is, while Massachusetts focused on expanding coverage by subsidizing low-income individuals with the dollars they already had, and is only now rolling out the reforms to allow employers and unsubsidized workers to have a choice of coverage. Utah is going about it the opposite way. They're starting in the private market and then working towards the public side. That's my point, is states are very different. Each can use the same things, but they have to find their own way and their own order for doing it that suits them.
Thank you.
Thank you, Mr. Deal. Mr. Gonzalez.
Thank you very much, Mr. Chairman. I apologize to the witnesses. There's so many conflicting appointments today and another hearing in judiciary, so I missed the testimony of the witnesses, except for the first witness, and I apologize. I may go over something that y'all covered, and again, do understand, though, that you have written statements in here. We have memos that are prepared by staff. We're going to have many hearings. Much of what you say here today, if not listened to by individual members of the committee, believe me, these statements will be reviewed and may well serve as the basis for some of the memos in the future as we take on different panels. I'll start with pronunciation. Is it Dr. Baker? How would he pronounce that?
Baker,
Baker, okay.
just spelled funny.
No, it's spelled in a very interesting way. But you were here for the witnesses' statements by the previous panel, were you not?
Yes.
Okay. And in your own statement, and I couldn't agree with you more, and I'm sure everyone that's here, in your statement you indicate, while there are many open questions in the design of the ideal system, with millions uninsured and rising costs threatening to swamp public and private budgets alike, we cannot afford to wait to act. Obviously, this committee is going to move forward. This administration is going to move forward. But I think you highlight the biggest obstacle, and that is something I referred to earlier when I was quoting from the two authors from the Harvard Business Review, an old article, no doubt, but we still face the same problem. How one balances these trade-offs is likely driven as much by philosophy as economics, and any reform will involve tough choices between competing values, and I think that is the biggest problem. If we can just stick on the economics, the efficiency, efficacy of what we do, we well served. But you've already heard words like socialism in the Big Brother and such. We need to get past that. So the question is, do we move forward now? And we do so. We're not talking about a single payer. Is that correct? That's not, now, there are many here that would like that, but I'm just saying, my vision is not, it's going to be a public option. That's the way I like to think of it. And as we move forward, again, leaving back ideologies, we've always said that we probably could form the most efficient system if the employer, which is the greatest purchaser of insurance, could lead that fight. That's what I had in the Harvard Review article, but that hasn't transpired in the past few years. So employers haven't been able to identify a better system. The consumer is ill-equipped. Ms. Politz, thank you very much for your comment. It was very sad in that Time article about someone from San Antonio who had an insurance policy that was totally worthless when his kidneys failed. So you can't say that the consumer is equipped to deal with this. The healthcare providers aren't doing it, not the medical professions. As a matter of fact, we have the specialties that compete with one another depending on what's going to be covered and when and how much. So wouldn't it be appropriate for the federal government, and I know someone has suggested let every state do it individually, but what are your views today about where we're going and what we are going to be proposing as far as the federal government coming in and playing a major role? Yes, Dr. Baker.
Thank you for the question. I think you've hit on so many important issues. One of the things I'd like to pick up on is that there are things that we cannot expect a private market to do. Private markets are great at pooling risks, and there are regulatory requirements to ensure that they do so fairly and effectively, but we can't expect private markets to redistribute money from rich to poor or from people with low health risks, the healthy, to people with high health risks, the sick. That kind of redistribution of resources is fundamentally social insurance, not private insurance. Social insurance need not be socialized. It could be done through the form of risk-adjusted vouchers, where people with high health risks take extra money that they're given. Maybe particularly low-income people get more generous risk-adjusted vouchers to ensure that they have access to the care that they need. That kind of redistribution happens a little bit now because of the way that we subsidize employer-provided health insurance. The way that we subsidize it encourages some risk pooling in the employer market by encouraging high-risk people and low-risk people to stay in the same pool, whereas otherwise low-risk people might flee. Now, is that the most efficient way to do that kind of subsidization of high-risk people? There are probably other ways that we could accomplish that goal that might have better distributional implications while preserving what's good about the risk pooling that's occurring right now. Any reform going forward that's going to take care of our most vulnerable citizens is going to have a component of social insurance, and that's the way we should be thinking about that function, not trying to impose that on private markets that are ill-equipped to do redistribution.
Thank you very much. I yield back, Mr. Chairman.
Thank you, Dr. Burgess.
Thank you, Mr. Chairman. Dr. Baker, if we could just continue on that line for a moment. One of the things that was talked about in the fall campaign was using the best practices of the states that have high-risk pools and trying to construct, or constructing rather, a mechanism for dealing with individuals who had conditions of medical fragility that would apply to their unique situation without changing the landscape for everyone else. Is that still a realistic possibility in the environment that we find ourselves today, taking the best practices from the states that have high-risk pools?
I think we certainly want to learn from the diversity of state experiences, and some states have high-risk pools that are functioning much better than others, and there are some general principles we can draw from that, more broadly subsidizing the high-risk pools rather than trying to subsidize them from narrow tax bases, for example, seems to be a more productive way of subsidizing them. Again, that is falling under the role of social insurance, where you're explicitly trying to redistribute some money to high-risk people who are uninsured, and the first goal, who are otherwise uninsured. I would think the first goal of a reform would be to get people insured as early as possible while they're healthy, so they can invest in their health, so they get the most efficient care they can, and a system that's designed to minimize the number of people in that condition in the first place could spread dollars a lot further. Then I think it would be great to learn from best practices at the state level to deal with people who fall through the cracks and to ensure that there's a broad enough subsidization that it doesn't drive a cycle that leads to more healthy people being uninsured, for example.
Okay, thank you. Dr. Kingsdale, on the Massachusetts experience, do you have a figure on the number of people who are paying the fine rather than buying the insurance?
So we have a lagging indicator because you file in April, of course, for the year before, and some people get extensions. So we have it only for 2007, and that was about 100,000 people. So
And so
about
you'll
1.5% of our population.
And then you'll have comparable data that you'll generate your filing period, April 15th, like the federal income tax?
Right, although about 10% extend till October, but we'll have pretty good data.
Yeah, I do that too.
Gotta try that.
Mr. Asselmeyer, if I could ask you on the, you pointed out that a lot of things are being done by the states now that they have a great deal of flexibility. In fact, I think we gave them a great deal of flexibility in the Deficit Reduction Act in 2005. Ezekiel Emanuel, writing with Ron Wyden in the Journal of the American Medical Association in October of this past year, alluded to that, but said the one thing the states cannot do is to alter the federal tax code. That is not within their power to do that. So could you speak to that?
Sure.
We heard a lot about taxing health benefits during the fall campaign. It appeared to me at the time to be something that was disfavored by the parties that won, but now it seems to be coming back in vogue, and I wonder if you might just address that.
I think it all depends on what you do with the money once you've taxed them. Most of the proposals I'm familiar with, and I've worked on about 8 different ones over the years for everybody from Mr. Army to Mr. McDermott on changing the tax treatment in Congress, would redistribute the money in the form of new tax credits to address some of the equity issues that were addressed earlier. The illustration would be the unsubsidized Commonwealth choice plans that are now being rolled out in the connector in Massachusetts and is envisioned in other states, whereby an employer would say, look, instead of offering a group plan, I'm going to take you down to the connector, and you will each, as employees, have a choice of that menu of plans that they have on offer, and you pick what's best for you. It's all guaranteed issue. If you leave me, you're still in the system, you still have your insurance, you take it with you, et cetera. That is structured in a way that under federal employee benefit law, it qualifies as employer-sponsored insurance and therefore qualifies for favorable tax treatment. The problem becomes that that favorable tax treatment is essentially the deduction against income and payroll tax. So if you're a lower wage worker who pays no income tax, that's worth 15 cents on the dollar to you. If you pay, say, that's your payroll tax. If you pay the employer-employee share 15 cents a payroll plus you're in the 15% income bracket, it's now 30 cents on the dollar, up to like 50 cents on the dollar for somebody who's maybe making $100,000 in the 28% bracket, et cetera, or 31%. So the idea of tax reform is to change that to redistribute the money more equitably. The state can only maximize their citizens' access to those federal benefits. They can't change the federal benefits. And there are other places in federal law where you could make changes that would aid the states.
Just one quick question. There, as I understand it right now, there's not a public option plan in the federal employee health.
No, there's no public option.
Would there be an advantage to putting a public option plan on the?
Well, my approach to the public option plan is it strikes me as one of these sort of fad and silver bullet things that go around, as I talked about earlier. I look at it this way. No matter how you cut it, the government always sets the rules. Now, you in Congress have a set of issues because some of the rules are set at the federal level, like federal employee benefit law in ERISA, HIPAA, COBRA, tax treatment of health care, the Medicare, Medicaid program, okay? But then other rules like licensure of providers, regulation of insurance is done at the state level. So your issue is which one's going to set which set of rules. But beyond that, you then have this issue, whether it's federal or state, if competition is going to work, everybody competing has to be on the same set of rules, right? Okay, now you get to point 3, which is, okay, can the entity that is inherently the rule setter field a team in the competition and have that fair? Are they going to, is a public plan going to have to meet the solvency requirements that a private insurer would have to meet in Ms. Kaufman's regulations? Are they going to have prompt pay laws? Are they going to have the same, can you sue them, or is sovereign immunity going to prevent you from suing them? When they deal with doctors, is it purely on a contractual basis, or is it like Medicare where if the doctor does something you don't like, you can say it's criminal because it's fraud. I mean, these are all questions you have to work out, and depending on how you answer them will depend on what it'll work on.
We've got to move on here. Thank
To
you.
coin a phrase.
Ms. Castor.
Thank you, Mr. Chairman, and thank you to the panel. Your testimony has been very thoughtful. And I was glad that you raised the value of the premium dollar for individual health coverage because I'm very skeptical in the individual market that consumers are getting the value of the health benefits they need. And I've read testimony and understand a lot of that dollar that consumers pay is going for other purposes other than the health of that individual. And Ms. Kaufman testified that in Maine, insurer administrative expenses have more than doubled in the past 8 years. This is at the same time when all across the healthcare spectrum, the premiums are going way up, and what you receive, what a family receives, just isn't what it used to be. And you also noted that in the past 3 years, the state's largest insurance carrier has declared $152 million in dividends. So as regulators and experts in the individual healthcare market, tell me, on average, how much of the individual health insurance premium dollar is spent on covered medical benefits, and how much is spent on marketing and administration, including high executive compensation and profit? And then how does this percentage or medical loss ratio compare to the medical loss ratio in employer group health insurance products, and what explains that difference, and what do you recommend? How can families and consumers get a better deal? Why don't you start?
Thank you very much for your question. I apologize for my voice. I'm trying to get over a cold. In Maine, we have, 65%, 65% medical loss ratio requirements. We have two companies in the individual market. One was not meeting the 65% loss ratio. They paid out, I think, 50-some cents on every dollar they took in for medical. And so exercising my authority as a state regulator, I ended up requiring them to refund the extra premiums they collected, and I also fined them $1 million for violating the state law. The other major carrier, which is the majority of our market, they pretty much pay out over 90 cents on the dollar that they take in medical. Now, there's been a whole lot of discussion about the cost of guaranteed issue and adjusted community rating requirements, those protections that allow sick people to access the private market. What that means is a lot of what the carriers take in, they do pay out in medical claims, but they also achieve healthy profits from being in the private market. Earlier, you heard that the private insurance market isn't really set up in a way that where carriers can assume too much risk. I would say if you're going to have a private market where insurance companies are allowed to profit, it's equitable and fair for them to take on risk. And we shouldn't expect taxpayers to pay for the sick while insurance companies are very profitable and make millions and billions of dollars in the industry. So if you're going to have a private system, the carriers have to assume the risk and the taxpayers should not bear the burden.
If I could add to that, I think it's to your question about how much administrative costs in the non-group market, it's highly variable with the rules that are set up. So in Commonwealth Care, our subsidized program, this is really kind of individual insurance, individuals sign up, our administrative costs, their administrative costs run about 8%. In the non-group market more broadly, in Massachusetts, they probably run twice that, maybe 12%, something like that, maybe not twice. In California, I'm told brokers earn 10% just for their services. So it depends very much, market by market, what the market rules are. And of course, one of the great things, potentials about the connector, remember my 20 to 30 minutes shopping, it's all on the web, is we can take the distribution costs of non-group insurance, because they are very, very high, even without large commissions. In an unorganized market, they are just very high. There are no scale economies. It's a one-on-one, hand-to-hand combat kind of situation to sell a policy and explain it. We can take those way down, and if you had scale economies with, on a national level, millions of people buying this way, you're talking about a couple of percentage rather than 10, 15%. But it does depend on the rules and how you structure the market.
Mrs. Castor, could I comment on that as well, or do you?
I'm sorry, you can comment. Sure, go ahead.
No, I'm sorry. I just this question comes up at the state level a fair amount, and I just would want to make the observation. I have suggested to states that what they could do, and in fact, John, you might be able to do this in the connector too, is to simply publish, apropos of the transparency, the loss ratios, and you publish what last year each company for each plan paid out in claims and what they retained for administration, profit, et cetera, with the proviso that you let them buy it down. So in other words, the dollar of premium that was either paid out in claims or refunded to the policyholders. Now, in that kind of a world, imagine you have two plans that are pretty much the same and cover the same benefits, et cetera, but one does a better job of managing care than the other. Okay, and the one that does a better job of managing care costs $4,000 instead of $5,000, but to get that care managed, their loss ratio is 70%, not 80%, because they had to spend more on administration. Which would you buy? Would you buy the one that spent more on administration but produced a $4,000 premium because they did a better job working with providers to manage care? Or would you buy the plan that was $5,000 but paid 80% out in benefits? If you put the information out, people can make those decisions, would be my suggestion.
Thank you. Mr. Gingrey.
Thank you, Mr. Chairman. Dr. Kingsdale, in regard to the Commonwealth Health Insurance Connector, I was curious to know, in comparing the Commonwealth Care versus the Commonwealth Choice, what has been the experience in regard to what consumers are choosing? Maybe that was in your written testimony. I did read it, but it was the wee hours this morning. But what is the breakdown at this point?
Yeah, they're two very distinct programs, so it's going to be hard for me to, I think, answer your question in a way that's going to satisfy probably the intent. So the 4 health plans that are available, and now we just could open that up to competition because they had restrictions in the original legislation, so we're adding a 5th, the first new entrant, major new entrant into the insurance business in Massachusetts in decades. But those 4/soon 5 all basically serve Medicaid and lower income folks. And while 2 of them also participate in the unsubsidized program that has...
So your Commonwealth Care is a subsidized program.
Right, and the Commonwealth Choice is unsubsidized. That is dominated by commercial insurers who are not in the low-income Medicaid.
So they really don't...
They're really very separate.
The patients or the consumers don't have a choice. It depends on their income status. If
Right.
they need a subsidy, then their choice is care.
Right.
If they don't need a subsidy, then their choice is choice.
I'll take a stab at one thing that might be helpful, which is because of the transparency and because the price differential, the premium differential, is 100% borne by the individual making the choice, there is disproportionately large purchase of lower price plans, even though the lower price plans may have by far much less brand name recognition than the higher price plan offering the same.
Well, let me ask you this follow-up. In regard to that, in the care plan, the subsidized plan, I guess physician fees, reimbursement rates for provider care is set. And are you finding that the many physicians, the acceptance rate of the care plan in the Commonwealth is pretty high?
Well, yes, and that's
are you running into problems with that?
Not really, and that's part of an ethos of shared responsibility. There is tremendous support for this program among physicians, hospitals, insurers, employers, et cetera. You know, all but 2 legislators, all but 2 of 190 voted for the thing. But the Medicaid MCOs that serve that lower income population Commonwealth Care, while the fees are not set, so they can get negotiated up, kind of the reference point, the starting point that people have in mind when they start those negotiations are Medicaid fees. And they say, oh, you're going to pay us 10% more than that, as opposed to the commercial side, where they might say, oh, we're starting at 150% of Medicare.
Right.
So it's a bifurcated set of negotiations.
Well, the reason I asked that question, of course, as we go forward and we're looking at all the options and hearing from all the experts in regard to, you know, the federal exchange connector, if you will, and the public option plan, you know, I just wonder if physicians are not forced, if they take any patients within the exchange, that they would also have to take the public option. But if not, and those fees are set so low, then you're going to have a lot of resistance, a lot of pushback. And again, what we're saying is, what good is that card if there's no doctor that's going to accept the public option? So that's a concern of mine that other than the additional concern of the crowd out. Let me shift real quickly to, I've already messed up once today on pronouncing one of my colleagues' names, but Doctor, I wanted to ask you on page 3 of your testimony, you speak at some length about market reforms that would, quote, realign insurer incentives away from avoiding risk and toward maximizing value. And you cite in your testimony the need for risk-adjusted mechanisms to ensure the market works smoothly and fairly for all insurers and policyholders. It would seem to me that these market reforms that you talk about in your written testimony might address some of the major breakdowns in health care today without requiring government control of care. And I would like, in the 15 seconds left, could you elaborate on these risk-adjusted mechanisms a little bit more, if the chairman would bear with me?
Yes, sir. Very simply, and I referenced 2 papers that I, in the footnotes in this testimony that are on our website that I wrote on the subject, if you want to go into it in more length. But essentially, in a market that is underwritten, where the insurer can turn you away, okay, what we have created is a high-risk pool that says, well, you can be guaranteed issue into there. Okay, so the person gets sent, who's sick gets sent over there. All right. If you have a market where the insurers can't turn you away, as we're talking about in the employer group market when you go to the connector, or if you were to expand guaranteed issue to the individuals, then you can't send the sick person off there. So what you do is you create essentially the same mechanism. It's just the insurers get in a room together and they put in the pot all their claims. I got 5 diabetics, you got 3 cancer patients, and we're going to sort it out and do it in a fair way. Now, there are many different ways to do that, but that's essentially the concept behind it. And my point is for the market to work well so that the insurer can say, hey, you know, I do a good job of treating diabetes. I can help coordinate your care so you get better results at a lower price, and then they get all the diabetics and somebody else gets all the cancer patients. Well, they can work it out in the back room on their own. That's what a risk adjuster pool does, okay? And it spreads the cost among everybody else, as opposed to saying, well, you're sick, go there, and then we're going to spread that cost over everybody else. So it's the same concept. It just depends on the market you have. Again, the papers discuss it in more length.
Thank you. I know I'm going to have to stop you because they're telling us we are going to have votes, and I want to get the last 2 members in here. Ms. Capps?
I'm sorry. Thank you very much. And I just got a tip, but I also have some questions I want to ask. This has been a very interesting panel, and I appreciate your contributions, each one of you. I will single out 2 people because 5 minutes goes very quickly, but I understand, Ms. Paulus, before I ask you my question, which I'm very interested in your response to, that you never got to weigh in on the risk adjustment or risk insurance.
Well, I didn't think I was asked, but...
No, that's why I'm giving you a chance to, if you could briefly do it. If you
Sure. I think reinsurance is a mechanism that has been tried on a voluntary basis in a lot of insurance markets, and public reinsurance has been tried in a few states as well. It's simply another way to subsidize health insurance at the end of the day if it's public reinsurance. Instead of subsidizing the premiums, which come regularly on the first of every month, you need to sort of reach in and find somehow the high-cost claims or the high-cost patients. So it, I think, can achieve the same thing. It is more complicated. There are many more transactions involved. At the end of the day, you need to make sure that if the end result is to subsidize the premiums, if that's what you want, to have the premiums reduced, then you need to have very, very good transparency to make sure that all of those savings from the reinsurance actually find their way back into reducing the premiums. Otherwise, you know, kind of like we're having with AIG now, you're putting a bailout in and you're not getting the result that you want.
Okay, thank you. Now, could I ask you the question I had intended, because, and you'll understand why when I tell you where I'm coming from. I'm hesitant about proposals that suggest that people should just purchase insurance in the individual market, whichever state they are from or wherever they are, because there are states like California that offer much stronger minimum protections for insurance. For example, California mandates screening for osteoporosis, while most other states do not. That happens to be a topic I'm personally very interested in. California also requires private insurers to cover treatment for eating disorders. More than half of the states do not. So that would make a huge difference to Californians if they got their insurance at another state that then refused to cover, and they came to California and refused to cover that. Wouldn't a public option be able to account for variances in state protections and be more consumer-friendly? Also, couldn't a public plan be formulated in a way that protects the strongest minimum coverage provided to individuals so that you would get the benefit from living in a state where these things were mandated?
It is absolutely up to the Congress to determine whether you want to set these standards at the lowest or the highest common denominator or somewhere in between. So you absolutely could create a public program that provides for comprehensive coverage so that people get the care they need everywhere. And I would defer to Mila on the other issues about selling coverage,
right,
in addition to the concerns about not being able to access benefits. I think there are real questions about, and I have enormous respect for Mila, but whether she has the resources to enforce against a plan in California or a resident of her state who would buy 3,000 miles away and then get into trouble. I think there would be very difficult.
And some of us in states like California are worried about the opposite. But I can see it going both ways. For example, people who work so hard in California to do the things that, like what I've just mentioned, this would be a huge step backward if we would be forced into what we would consider a step backward. But I also want to, I'm going to need a little extra time, Mr. Chairman, because I kind of did something else too. But because, Ms. Kaufman, I'm really interested, you can speak to this one issue if you'd like to, but I wanted to learn more about programs that you have been able to create, which bridge the gap between Medicaid-covered individuals and those who are uninsured but don't quite qualify for Medicaid. For example, I'll tell you where I'm coming from in my district. In fact, in each of the 3 counties I represent, we have seen some very innovative proposals, such as county-organized health systems, which better capture all Medicaid-eligible individuals, and using a sort of a managed care model, a nonprofit, but a locally organized one. And also then there's another program in Ventura County which refers to the person I acknowledged this morning in my opening statement. Because she lived in Ventura County, those who are uninsured but don't qualify for Medi-Cal or Medicaid in Ventura County have access to another program, and they've seen such a dramatic decline in emergency room visits for non-urgent care as a result. And that's the kind of outcomes we should strive for, because they can put that money back into the system and help extend it to more individuals. The reason it works, and this is what I would like you to verify or add to, is because it's public-public partnership, whereby the local government can provide the innovation and creativity in creating a system that works best for their particular population. Can you talk, I know it's briefly now, about how you've done this? How have you managed to tailor a plan that Maine really benefits from?
We have a slightly different partnership, public-private partnership, which I call a bridge program. It's called Dirigo Choice. Right now, due to funding challenges, it's not open for new enrollment, but essentially the state helps to pay for the premiums. There's a private insurance company that provides the coverage, but it's the Dirigo agency that negotiates the benefits, the price, and people who really can't afford the private coverage but are working and make too much money to qualify for the public insurance program, that's the place where they can get coverage, where there's a private payer that pays their medical bills and the state helps them with the premiums. The program has served over 20,000, 23,000 people, both small business workers, their families, as well as individuals. Unfortunately, because of funding challenges, it hasn't been open for new enrollment, and as premiums have gone up even slightly in that program last year, I believe it was 11%, which in our market is slight. I can tell you that the major carrier recently came in with a premium increase of 40%, and actually that was for their consumer-driven product, higher than the other products they sell. So 11% premium increase for the Dirigo Choice is not as high as the rest of the market is asking for, but that forced some people to leave that program because they just couldn't afford even the 11%. Due to limited incomes, their wages have not gone up, and everything else has gone up, the price of food, gas, energy. So it's been really difficult, absent a strong and real financing mechanism. There's been a lot of talk here that states could do this. If we were able to address...
I'm going to have to cut you short because we have one more member and we have 3 votes, so...
Could you finish your sentence? I just want
Sure, go ahead.
States need help. If we were able to tackle the healthcare crisis, we would have done it. We want to do it. We cannot do it alone. Despite Ed's comments earlier, we need help, and we want to be your partners in tackling the healthcare crisis.
So to make this work, there are times when the federal government should just really shift the balance a little bit more. When states are having a hard time, or that's one of the ways that it could survive. Okay, thank you.
Thank you. Mr. Shadig.
Thank you, Mr. Chairman. Ms. Kaufman, I just want to make sure, did I hear you earlier say that there are only 2 carriers in the individual market in Maine?
Actively selling, that's correct.
Tragically, I think that's the situation in most states, where people forced into the individual market have almost no choice whatsoever. A public plan which they could buy as an individual would be another option for them that would give them at least one other choice? Is that you understand?
Yeah, people want real choices to the extent that the public plan offers good coverage, adequate coverage that pays for you when you're sick. That is a real new option that people would benefit from. I've talked to providers and individuals alike, and people are losing faith in the private market. There's this perception out there because the profits have been so high that claims decisions are not made in the best interest of the insured person. And I can tell you they are, but the perception there is not the reality. And I think many people would choose the public option because of those reasons, and I think the public option would give would
I understand
mean real competition for the private plans out there.
Well, I believe that there have been instances where benefits have not been paid in the interest of the beneficiaries. Indeed, I conducted a long campaign against HMOs, who I think were denying care to try to make profit. But we have people forced into the individual market often because of the tax treatment. Some people can get health care inexpensively through their employer on a tax-favored basis, but if you go buy it in the individual market, you pay with after-tax dollars, making it much more expensive. Would you then favor mechanisms that would create other group purchasing options so that people could pool through a mechanism other than their employer?
I think we need a more equitable way to help people buy coverage, and people shouldn't be disadvantaged because their employer doesn't offer or they're
I couldn't agree more.
In the individual market. I think in terms of pooling, the price of pooling Pooling in itself doesn't get you anything unless there are real protections and oversight around pooling. So I would be very supportive of increasing and incentivizing more pooling as long as there are real protections for people who want to be in those pools.
Mr. Hasemeyer, high-risk pools, as I understand it, you just tried to explain or discussed with Dr. Burgess the issue, or maybe it was with Dr. Gingrey. People who are high cost can either be put in a high-risk pool or kept within the existing pool of insurers in a given state. Is that what the paper you discussed addressed?
Right. Basically, what you're doing is you have both of them, a high-risk pool or a risk transfer pool, are mechanisms for pooling on a market-wide basis. So you start at the individual insurer level where they say, well, I get some sick people and some healthy people, and there's a cross-subsidization of the sick by the healthy. The next step is to say, well, we're going to take all the insurers in the market and we're going to do the same sort of cross-subsidization for the whole market, defined however you want, a region, a state, whatever, but for purposes of this, probably a state. Now, at that point, you have a decision. If the insurance is provided to the individual on the basis of underwriting where the insurer, a seller-driven market where the insurer can refuse to offer coverage, then what you do is you send that sick individual over to a high-risk pool. The excess cost is then passed back on to all those people you did give coverage.
I wrote the state high-risk pool legislation encouraging.
So all I'm saying is a risk transfer pool is simply the same mechanism, but it's for a market where it's guaranteed issue and you can't send the individual off. You take the individual, you send the claim off.
Let me change topics. Ms. Capps just talked about the fact that she loved the California mandates. She likes certain things that are mandated under California law for coverage. You mentioned earlier one of your concerns about a so-called public plan, and I think you're right. It is the current system in vogue, or the idea in vogue, would be, well, what does it cover, what doesn't it cover? I think you also touched upon a point that I think I touched upon in my questioning earlier, and that is, if the government offers a public plan and the government also sets the rules for that plan and for all the other plans, isn't the government both a player in the game and the referee of the game? And I'd like to see if you do agree with that point and if you'd expand upon it.
Well, very simply, the last point, if the government will always be the rule setter. So in a state, any state right now, they could set up a public plan in competition. I mean, Massachusetts could do it with the connector if they wanted to, okay? You will always have that question of, do they play by exactly the same rules? Because what we know is that when you have different rules, then you will have market segmentation. We've seen this in Maryland. We've seen this, I mean, I've just been dealing with Washington State, where they allowed association plans, one set of rules for the small group market, and commercial insurers, another set of rules, and it's created all sorts of problems. So the first rule, whether it's a public or private plan or two groups of private plans, is everybody playing on the same rules. So that's one level of questions that you would confront regardless at any state. Now, if you're at the federal level, you have all those questions, but now you have an additional set of questions. And the additional set of questions is, well, the 50 states have different standards. As Representative Capps pointed out, whose standards are we going to apply nationally? Okay, so you have all the same set of questions you have to deal with, plus you have another set.
Dr.
We're going to
Kinsdale,
have to end it.
Dr. Kinsdale, you said there are 100,000 people who have not joined or not paid in. They're simply unenrolled. What in the first year, right? That was going back to 07. What's the system do for or about them? How do they get care?
Quickly, because we have to vote.
Okay. So if they are, well, if they're low income, they wouldn't be subject to that penalty. So they would basically be self-pay. They're part of the 2.5% that we haven't insured.
All right.
Okay.
We're going to run out of time if we want to vote. Thank you all. Again, this has been very helpful in our efforts to try to put together legislation. And you may get some additional questions from members that you can respond to in writing. The clerk will notify you of that. But without objection, this meeting of the subcommittee is adjourned. Thank you.
Thank God they have to go vote.